Usually when we talk about a medical diagnosis, there's this expectation of clinical precision. It almost feels like engineering.
Right, yeah, very mechanical.
Exactly. Like you break your arm, the x-ray shows that jagged white line on a black background, and the doctor just points to the film and says, well, there it is.
It's binary. I mean, the bone is either intact or it's fractured. And there's actually something really inherently comforting about that clarity.
Oh, definitely.
We like our physical ailments to be visible,
Yeah.
to be neatly categorized. We want a straightforward roadmap for how to fix it.
But then, you step into the world of intimate women's health, and suddenly that trusty x-ray machine is, well, it's pretty much useless.
Yeah, completely useless.
We're looking at a diagnostic landscape that is, honestly, it's really murky. Because for you, the listener, you might be dealing with conditions that are often completely invisible to the naked eye.
Unseen, but very real.
Right. And heavily stigmatized by society, but just incredibly painful for the patient. But today, we are doing a deep dive into a stack of clinical trials, some detailed medical transcripts, and these emerging clinical protocols focused on a tool that is fundamentally changing how medical science approaches these exact issues.
It's a huge shift.
It really is. It's this revolutionary regenerative treatment called exosome therapy.
And the clinical data we are looking at today is truly a paradigm shift, because we have sources detailing how medical professionals are taking this single biological tool and completely adapting their treatment protocols to address two just drastically different conditions.
Night and day conditions.
Exactly. On one hand, you have the focal, dense, really fibrotic scarring from a prior episiotomy or a childbirth tear.
And then on the other hand, you have the widespread generalized tissue degradation that's known as vaginal atrophy.
Right.
It's just a fascinating look at how the exact same cellular messengers are deployed in completely opposite ways depending on the actual physical terrain of the tissue they're trying to heal. Okay, let's unpack this.
Yeah.
Before we can really grasp how these clinical protocols change from patient to patient, we kind of need to establish what this tool actually is. So let's start at the very baseline. What exactly is an exosome?
That is the perfect starting point, honestly, because there is a massive misconception circulating right now.
Yeah.
Especially, in the wellness space.
Oh, yeah, the wellness clinics.
Yeah, people very frequently confuse exosomes with stem cells, but, and this is crucial, exosomes are not cells.
Yeah, I noticed that in the clinical protocols. They don't even have a nucleus, right? Which means they don't contain any donor DNA.
Exactly. That lack of a nucleus is a defining characteristic. They are microscopic extracellular vesicles. And just to give you a sense of the sheer scale we were talking about here, they measure between 30 to 150 nanometers in size. Yeah, it's unimaginably small. You could literally fit millions of them on the head of a single pin. And for a very long time, medical science actually thought these tiny vesicles were just cellular exhausts.
Like trash.
Yeah, just the garbage a cell threw out after doing its actual work.
But they aren't debris at all. I mean, they are actually the communication network itself.
Right. They are incredibly powerful paracrine messengers. And that word, paracrine, is key here. Because unlike a hormone like estrogen or testosterone, which, travels through the entire bloodstream to deliver a systemic message, paracrine messengers operate locally.
So they just talk to the immediate neighbors.
Exactly. They communicate with the cells immediately next door in their specific neighborhood. So think of them as tiny, highly protected shipping containers.
Okay.
The outside of the container is a lipid bilayer. It's a protective fatty envelope. And inside that envelope, they're loaded with a highly specific cargo of proteins, lipids, messenger RNA, and vital growth factors.
And the sources specifically highlighted growth factors like VEGF and TGF-beta. And, well, if I am reading the biochemistry right, VEGF basically stimulates the formation of brand new blood vessels, while TGF-beta acts as the engine that drives actual tissue repair.
That is exactly the payload.
Right.
And because, like you mentioned, they don't carry a nucleus or donor DNA, they are highly biocompatible.
So they don't cause reactions?
Right. They don't trigger the kind of severe immune rejection you might see with foreign cell or organ transplants. The body basically doesn't view them as foreign invaders. It just views them as biological instructions.
So, think of exosomes like foremen arriving at a construction site. They don't actually bring the physical bricks, and they don't do the heavy lifting or the physical labor themselves.
No, they don't.
Instead, they hand a set of blueprints and instructions, which are, the mRNA and the growth factors, to the local workers who are already on site.
I like that analogy.
And in this biological scenario, those local workers are your fibroblasts, right? the cells responsible for actually building structural proteins like collagen. The foremen just tell the local workers exactly how to rebuild the neighborhood.
What's fascinating here is how these vesicles actually negotiate with the immune system the moment they arrive at that construction site. Because they don't just boss the fibroblasts around, they act as immunomodulators.
Meaning they change the immune response?
Yeah, they have the ability to induce something called macrophage polarization.
Macrophage polarization. Okay, that is a pretty heavy piece of medical terminology. Let's translate that for the listener who, isn't a cellular biologist.
Fair enough, yeah. So think of macrophage as the security guards of your immune system.
Hmm.
When there is tissue damage or tearing or chronic irritation, these guards naturally shift into a pro-inflammatory state.
Okay.
In immunology, we call this the M1 phenotype. The guards are essentially sounding the alarm, causing swelling, heat, and chronic inflammation to sort of isolate the damage.
Which, that's helpful in the short term if you have a bacterial infection, but terrible if it becomes a chronic state of pain.
Exactly. So when the exosomes arrive on the scene, they chemically signal those security guards to stand down. They force the macrophages to shift into a reparative state, which is known as the M2 phenotype.
Oh, wow.
So they literally turn the local microenvironment from a state of chronic alarm and inflammation into a state of active, quiet repair.
That is incredible. They're fundamentally altering the behavior of the tissue itself, turning off the alarm bells and handing out brooms to clean up the mess.
Basically, yes.
So if these foremen know how to rebuild a crumbling neighborhood, how do clinicians actually deploy them when the entire landscape is failing? Because that brings us to our first specific condition in the sources, genitourinary syndrome of menopause, or GSM, which encompasses generalized vaginal atrophy.
Right.
What is the actual physical reality of the tissue when a patient is dealing with this?
So with GSM, the root cause is usually a profound drop in estrogen. But the result is a cascade of structural failures across the entire vaginal wall. This is a global issue, not a small localized tear.
It's everywhere.
Yeah. The tissue undergoes profound thinning. The body stops producing adequate type I collagen, which is that thick, strong, supportive collagen. The natural acidic pH alters, and that causes a massive drop in the beneficial lactobacilli bacteria that normally protect the microbiome.
And the clinical notes also really emphasize that the physical barrier itself breaks down. They pointed to something called tight junction proteins, specifically claudin-1 and occludin.
Yeah, and those proteins are essentially the biological mortar holding the cellular bricks together.
Okay.
They maintain the integrity of the mucosal barrier, keeping moisture locked in and keeping irritants out. When those tight junction proteins weaken and degrade, the tissue becomes incredibly fragile.
Just structurally weak.
Exactly. In clinical terms, gynecologists describe it as paper-thin and friable. And friable just means it tears and bleeds with almost no friction.
Oh, what?
For the patient, it causes immense discomfort, a sensation of constant burning, and really severe pain during intimacy.
So we have this vast surface area of tissue that is paper thin, bone dry, and easily damaged. And this is where the delivery protocol becomes so important, right?
Very sure.
Because you can't just take a traditional needle and start jabbing this delicate, friable tissue dozens of times to inject the exosomes. The physical trauma of the needle alone would cause more damage than the treatment could even fix.
Yeah, the structural reality of the tissue dictates a completely different approach. So the protocol shifts entirely away from aggressive needle injections. Clinicians instead utilize a broad, sort of shallow dual therapy approach to cover the vast surface area safely.
How does that work?
Well, the first step involves energy-based devices. Typically, this is a fractional carbon dioxide laser like the Mona Lisa Touch, or maybe a fractional radiofrequency device like Morpheus AV.
Wait, let me push back on this a second because it sounds kind of wild. If you, the listener, are picturing tissue that is already paper thin, intensely dry, and tears easily, isn't shooting a medical-grade laser at it or applying high-heat radiofrequency completely counterintuitive?
It sounds crazy, I know.
Doesn't that risk burning or just obliterating the very little healthy tissue they actually have left?
It sounds highly alarming, and it's a very natural reaction to have. But the clinical rationale here is actually quite brilliant. The devices are calibrated very specifically. We aren't talking about ablating or burning away the tissue.
Okay.
It is a process of highly controlled, non-ablative heating.
So it's penetrating to a very specific shallow depth without destroying that fragile surface layer?
Precisely. And that controlled, precise heating does something crucial on a cellular level. It induces the expression of heat shock proteins, specifically one called HSP70.
Heat shock proteins.
Yeah. These proteins act like a biological shield or a chaperone, rushing in to protect the existing cells from oxidative stress. But more importantly for the therapy, the fractional laser creates thousands of microscopic channels across the entire vast surface area of the vaginal wall.
Without burning the skin off.
Right, without causing epidermal sloughing, meaning the top layer of skin doesn't peel off.
Ah, so they are essentially aerating the lawn. They are prepping the ground so it can actually absorb the treatment.
That's a great way to look at it,
Yeah.
because immediately after those thousands of microchannels are opened, the clinician applies a highly concentrated exosome serum topically.
Just rubbed right on.
Yeah. The sources highlight advanced products like ASCE plus IRLV, which features 5 billion exosomes derived from rose stem cells specifically formulated for delicate mucosal tissue.
5 billion exosomes applied directly to the surface. And because the laser just created those microscopic pathways, the serum isn't just sitting harmlessly on the surface acting like a basic lubricant.
Exactly. The microchannels bypass the failing mucosal barrier, allowing for deep, uniform penetration of the exosome serum across the entire affected area.
And what happens when they get in?
Well, once those exosomes enter the tissue, they rapidly go to work on the underlying chemistry. Their first major action is to downregulate matrix metalloproteinases, specifically MMP1 and MMP3.
I remember reading about those. Those are the rogue enzymes responsible for breaking down the tissue in the first place, right?
Yes. So the exosomes deliver the chemical blueprint telling the body to stop producing the enzymes that are destroying the extracellular matrix. Simultaneously, they stimulate HAS2.
Which is?
That stands for hyaluronic acid synthase. This signals the local cells to start producing their own natural hyaluronic acid again. So the tissue essentially rehydrates itself from the inside out, while those tight junction proteins, the mortar we talked about earlier, they rebuild and lock the moisture in.
That makes perfect sense. It's a broad, sweeping treatment designed for a broad, sweeping problem. You use the energy device to create the channels, you flood the vast surface area with billions of cellular blueprints, and you let the tissue rehydrate and thicken uniformly.
Exactly. It's brilliant.
But here's where it gets really interesting. How does the clinical protocol completely flip when the problem is the exact opposite?
It's a 180-degree turn.
Because we just talked about paper-thin, delicate tissue. Now let's talk about the absolute inverse, episiotomy scars.
This represents a completely different biomechanical challenge. An episiotomy scar, or a severe spontaneous perineal tear, which is often located at the posterior of the foreshead, the very bottom of the vaginal opening, is not a broad, thin, fragile issue.
No, it's not.
It is a dense, hard, localized roadblock of fibrotic tissue.
And just to ensure we are all on the same page here, an episiotomy is a surgical cut made by a doctor during childbirth to enlarge the vaginal opening. And while the practice is, becoming less common, millions of women have them. And the scarring from this incision can cause years, sometimes decades, of painful sex, which is clinically called dyspareunia. And it can also cause something called allodynia.
Yes, and allodynia is a state of severe nerve hypersensitivity.
Meaning things that shouldn't hurt do hurt.
Exactly. A very light touch or normal friction that absolutely shouldn't be painful feels like an intense burning or a sharp tearing pain. This happens because these subepithelial nociceptive nerve fibers, the raw pain receptors, literally get trapped, compressed, or damaged within that dense, chaotic web of scar tissue.
So applying a topical exosome serum over a light laser treatment isn't going to do a single thing here. I mean, the tissue is far too thick.
No, it wouldn't penetrate.
The barrier is physical. It's like trying to water a concrete driveway and expecting a flower to grow.
A topical spread is entirely useless for this pathology. The protocol has to adapt to a highly targeted, direct submucosal injection. We are moving away from treating a fragile, widespread surface area to physically penetrating a dense, localized, fibrous wall.
So we are moving from the sprinkler approach of treating atrophy directly to the sniper approach of treating a scar.
The sniper approach, yes.
How do the clinicians actually get the exosomes inside a hardened mass of scar tissue?
They use specialized, incredibly fine tools. The sources detail the use of a 32-gauge, 4mm syringe tip.
That sounds tiny.
It is. For context, the 32-gauge needle is practically as thin as a human hair. They infiltrate the specific scarred zone, point by point, millimeter by millimeter. Often they will dedicate an entire 1 to 2 cubic centimeters of the exosome product entirely to this one tiny localized area of the posterior fourchette.
That is a massive concentration of cellular instructions forced into a very small, confined space. What is the biological goal here? Because traditionally, if a patient presents with a severe, painful scar, a surgeon might just go in with a scalpel and mechanically cut the scar tissue to release the tension.
Right, and that traditional surgical approach is called mechanical adhesiolysis. But the obvious flaw there is that cutting tissue creates new trauma, which very often leads to the formation of new, and sometimes worse, scar tissue.
A vicious cycle.
Exactly. The goal with the exosome injection is to biologically reverse the fibrotic phenotype.
Reversing the phenotype. So we are changing the nature of how the cells behave once again.
If we connect this to the bigger picture, exosomes are fundamentally smart signals. They don't just blast one single instruction regardless of where they are, they read the local microenvironment.
Oh, that's fascinating.
When they were applied to the thinned atrophic tissue in our first example, they read the lack of collagen and signaled the tissue to thicken, stop breaking down, and produce hydration. But when they are injected deep into this thick fibrotic scar tissue, they encounter a totally different environment and deliver a different message. They signal the tissue to soften. They instruct the local fibroblasts to reorganize the chaotic, disorganized collagen fibers of the scar matrix, and they promote the repair of those trapped, damaged, nociceptive nerve fibers.
They're essentially telling the scar tissue to stop acting like a rigid defensive scar and start acting like healthy, flexible, normal mucosal tissue again.
Exactly. They modulate the inflammatory response that created the dense scar in the first place, and they promote neovascularization.
The blood vessel growth.
Right, the growth of healthy new blood vessels into the scar, which allows the trapped nerves to finally receive oxygen and heal. It's a localized deep intervention for localized deep problem.
It really highlights how incredibly adaptable this biological therapy is, purely based on the clinician's delivery method. But, whether you are treating a widespread desert like GSM or a localized roadblock like an episiotomy scar, the success of this therapy relies entirely on the quality of the blueprints being delivered.
Absolutely.
Which brings us to a massive structural question about the industry itself. Where do these exosomes actually come from, and how do we know the vials arriving at the clinic are safe?
This raises an important question because sourcing and manufacturing are critical. This isn't a compound you can just mix up in a back room.
Right, it's not a DIY project.
Not at all. The sources mention several origins for clinical-grade exosomes. You have ADMSCs, which are mesenchymal stem cells derived from human adipose or fat tissue. You have exosomes harvested from umbilical cord tissue. And as we mentioned with the ASEE plus IRLV product used for the topical atrophy protocol, you have botanical sources.
Like rose stem cell.
Like rose stem cell.
I have to admit, when I first read rose stem cells in the sources, it sounded like a marketing gimmick for a high-end face cream you'd buy at a department store, not a rigorous clinical gynecological treatment. I mean, why would a human cell care about instructions from a plant?
It does sound cosmetic, I agree, but the science is actually deeply rooted in evolutionary biology. At a fundamental nanoscale level, the lipid bilayer of an exosome extracted from a plant functions almost identically to a mammalian one.
Really?
Yeah. Our human cells don't care that the exosome originated from a rose. They just read the universal biological language of the lipids and the anti-inflammatory biosignals packed inside. It's like biological Esperanto. And plant-derived extracellular vesicles carry powerful anti-inflammatory signals that just happen to be highly biocompatible with human mucosal barriers. But regardless of whether the source material is human fat, an umbilical cord, or a botanical stem cell, the manufacturing process is what separates a genuine clinical medical product from snake oil.
And the sources spend a lot of time on the extraction process. So what are the red flags or green flags a clinician or, an educated patient should be looking for?
Well, the clinical literature heavily emphasizes the method of extraction and purification. Historically, a process called ultracentrifugation was used.
Spinning them really fast.
Yeah. This essentially involves putting the cellular material in a machine and spinning it at over 100,000 revolutions per minute to separate the components by weight. The problem is that the extreme G-forces can actually crush or shear the delicate lipid bilayer of the exosome.
So you essentially put a fragile package in a washing machine on the highest spin cycle, and the shipping container gets ruined before it ever reaches the patient.
Exactly.
The vital mRNA and growth factors just spill out into the ether.
The gold standard highlighted in the modern clinical protocols is a process called tangential flow filtration, or TFF. Instead of violent spinning, TFF gently flows the material across a specialized membrane filter. It's like a gentle river flowing over a grate where only the perfectly sized, intact exosomes slip through without being crushed. This preserves their structural integrity and their biological payload.
So why should you, the listener, care about something as deeply technical as tangential flow
It's
filtration?
important to know.
Because if you or someone you love is navigating these very vulnerable, intimate health spaces, understanding the difference between a highly purified, intact clinical product and a subpar, crushed cosmetic one is the absolute key to being an empowered patient. You want the intact shipping container.
And beyond the extraction method itself, the final product must pass stringent quality control. We're talking about GMP good manufacturing practice and standards set by ISAV and ISAV, which are the international societies that strictly regulate extracellular vesicles.
So there is oversight.
Definitely. The final vials must be rigorously tested to ensure they are completely free of endotoxins, mycoplasma, and viral pathogens.
Because, I mean, you are introducing these powerful signals directly into the human body.
Exactly. And this raises another important point about patient selection. Regenerative medicine is incredibly exciting, but it requires strict clinical caution.
It's not for everyone.
Right. Exosome therapy, despite its potential to heal, is contraindicated, meaning it should not be used, or requires extremely careful assessment in cases of active pelvic infections, a history of certain cancers, or unexplained vaginal bleeding.
And that makes total biological sense. If you introduce a powerful, concentrated growth signal into an area of the body that might have undiagnosed malignant or cancerous cells, you could potentially stimulate the exact wrong kind of growth.
Precisely. A thorough medical assessment by a qualified specialist is non-negotiable. This is not a casual spa treatment. It is advanced cellular medicine that actively alters tissue behavior.
Okay, let's take a breath and look at the journey we've just been on. We have seen how clinical protocols brilliantly adapt the delivery of these microscopic foramen based on the exact nature of the tissue damage.
It's a huge step forward.
Right. On one hand, we see clinicians utilizing laser-assisted microchanneling for the broad, shallow repair of genitourinary syndrome of menopause, literally bypassing the broken mucosal barrier to rehydrate paper-thin tissue from the inside out. And then on the other hand, we see them deploying deep, targeted, highly concentrated syringe injections to break down and completely remodel dense, painful episiotomy scars point by point.
It really demonstrates that the future of medicine isn't just about having a powerful new tool in the doctor's bag. It's about deeply understanding the physical microenvironment of the disease and altering the delivery mechanism to match it perfectly.
The approach is everything.
The exosomes provide the raw instructions, but the clinician's delivery protocol dictates how and where those instructions are received.
So what does this all mean? It means that intimate healthcare is evolving in a really profound way. We are moving away from simply managing symptoms or, handing out temporary topical lubricants, or worse, accepting physical decline and pain as just a normal part of aging or post-childbirth trauma.
Which patients have been told for decades.
Way too often. But we are moving into an era of actively commanding cellular regeneration.
It is a fundamental paradigm shift from structural symptom management to actual biological reprogramming.
Which leaves us with a lingering thought for you to mull over today. If medical science can now use nanoscale vesicles extracted from human tissue, or even a botanical rose, to completely reprogram how our cells heal a decades-old childbirth scar, or basically reverse the biological aging of a failing mucosal wall, what other permanent conditions in the human body are simply waiting for the right set of microscopic instructions?
The biological blueprints are already there. We are just finally learning how to read them and, more importantly, how to deliver them.
Thank you so much for coming along on this deep dive into the source material with us today. We started by talking about the clean, binary precision of a broken bone on an X-ray versus the murky, complex waters of intimate health. But maybe those waters aren't so murky anymore. Maybe with the right microscopic messengers and the right clinical delivery, we are finally learning how to navigate them. Take care and keep asking the deep questions.